gentlemen. A warm welcome to the Bhurban Conference 2022. It was supposed to be held in May, but now, due to the commitment of the federal, they did not think that they should stop it. So, like I said, lecture and education, knowledge should be continued and should not be stopped. So, hats off to the federal for continuing with this process. So, today we will be discussing or having a panel discussion on diabetic macular edema. So, we'll go through or walk through what, why, and how diabetic macular edema happens and what to take care of, how to take care of it. So, I'd like to introduce first the chair and the co-chair. The chair today is Brigadier Saqib Naeem, and he is the commandant of Armed Forces of Institute of Ophthalmology and a great colleague and a friend of mine. Welcome, Dr. Commandant Brigadier Saqib.
Thank you, madam.
And I'd like to welcome co-chair Dr. Saifullah Tareen. He's come from Quetta and a very, very fine man. Finally, we'd like to introduce the panelists for today, and we have all the professors from all over with dominance of KBK at the moment. And we have Professor Sanaullah Jan, welcome sir. Professor Amir Awan from Islamabad, Professor Mir Ali Shah, Professor Tariq Malwat, and the General Secretary of the Federal who brought all this happening, or whatever is happening today is because of him, Professor Shahzad Seeth. And I'd like to welcome all the audience for being here today. Now, the format of this panel discussion is that we have 18 questions and a few have like part A and part B. So I would like to request the panelists to keep your answers like to the point, and if we can finish it within 2 to 3 minutes, so we'll be able to finish all the 18 questions. And if we have time, I'd like to take some, suggestions and answer from the audience and also, but I'll ask them. So if they have anything in mind, they can just, raise their hands and we can add, take their suggestion or their experience as well. So that's me. I'm the moderator for today. My name is Professor Dr. Humakyani Sehgal, and I've come from Lahore, and I work as a head of department of Atma General Medical University, Lahore. So let's begin with the panel discussion. The first question from the person who's sitting right in front of me is Professor Tariq Malwat. So what comes in your mind when you are looking at a patient with diabetic macular edema?
Bismillahirrahmanirrahim. The first thing that I try to notice is whether the patient is having center involving DME or the center is not involved. Because the whole story starts then. If the center is involved, the patient will need investigations, maybe OCT, sometimes FFA, and the other blood profiles as well. But if the center is not involved, the patient may not need any treatment or any investigation and just follow up. So the first thing that I notice in a case of DME is whether center is involved or not.
Shasa, would you like to add something to it?
Thank you very much. It's such a vast question. We're looking at the beginning at the same time looking at the end of this DME. So it's the whole picture of patient, including his systemic diseases like hypertension, diabetes, lipidemia, and the patient's, in fact, the patient location from where he is coming, what treatment he has got till now, that's important. What is the effect of that treatment? Either the patient is going to be regular in coming again and again every month or not, the expectation of the patients. And at the same time, we want to exclude whether this macular edema is associated with any epiretinal membranes or macular traction. So we have to decide there, and then that this patient will benefit. If it is associated with the membrane, naturally this patient will not benefit like other patients who don't have this, especially thinking about steroids and anti-VEGFs.
Okay. Thank you. Sanaullah Jan, looking at all this, first thing is that what it crosses my mind, I think like Mir Ali Shah said, it's a very, very vast the answer is vast. You can't condense it into a small section. So we're going to move forward from that and take each step. The first question is basically the basis of what we're going to do in the next questions. So, Sanal Saab, what do you think, what is the criteria, which is the most important criteria when you look at or you concerned with when assessing a patient with DME?
I think that Tariq and Nirisha, some part of this question were already answered. I would just like to comment about the first question also. The first thing which comes into my mind when I'm dealing with diabetic patient is his diabetic and his risk factor control for retinopathy. This is the first thing when the diabetic patient comes to me. And then I come towards the eye. So again, center involving, non-center involving, and then you go for OCT and then proceed at recording.
Perfect. And Amir, how would you like to add in?
I think briefly I'll comment on the first question as well. So when the patient comes, I think it's important to look at the patient generally as well. Is it emaciated patient? Is patient look like on dialysis, pale looking, dark skin, very thin? Then as already mentioned about that the glycemic control, cholesterol, so that all things are guiding you that the treatment is going to help much or not. So coming to the criteria in assessment of diabetic macular edema, I think vision is a very important indicator. When patient comes to me, the brief history is taken, vision is there, so that gives me a clue that how much the vision is affected. And if there are not much media opacity like cataract, vitreous hemorrhage, so you assume that it's happening due to the macular problem or it's happening due to extensive proliferative diabetic retinopathy, that can be there. So vision is the important criteria. Then severity of diabetic retinopathy, that's again important with diabetic macular edema. Is patient having proliferative diabetic retinopathy? Is patient having severe non-proliferative diabetic retinopathy? So it's very important to know about that. So because your all management then depends accordingly. And then as briefly mentioned, investigations, you go along further.
Okay. So coming to the third question, Colonel Shazan, we've divided into two, into the anatomical and functional. You can, combine the two like this, or you can separate it into two. So what are the prognostic factors that are relevant for anatomical and functional success of DME?
Madam, I would like to combine all the 4 questions together.
That's perfect. Continuation में चल
सबसे
रहा है.
पहली चीज़ जो थी, वो बड़ा अच्छा क्वेश्चन था कि जब पेशेंट आया तो हमारे जहन में क्या आ रहा है. पहली चीज़ जो मेरे जहन में आएगी, दैट इज डज द पेशेंट नो दैट ही और शी इज़ डायबिटिक. कई दफ़ा तो हमें पीछे नज़र आता है और पेशेंट को नहीं पता कि वो डायबिटिक है. एंड इफ़ द पेशेंट नोज दैट ही और शी इज़ डायबिटिक, डज द पेशेंट नो द ग्रेविटी ऑफ द डिजीज़. अगर डायबिटिक मैकुलर एडीमा हो चुका है, इसका मतलब है कि चीज़ें काफ़ी हद तक आगे चली गई. बिकॉज जब मुझे डीएमई नज़र आ गया, दिस मीन्स कि अब उस पेशेंट का और मेरा ताल्लुक अगले 10, 15, 20 साल टिल दैट पेशेंट इज़ अलाइव वो रहना है. थर्ड थिंग इज़ द सोशियो इकोनॉमिक बैकग्राउंड ऑफ दैट पेशेंट. बिकॉज मैंने अपनी जो टारगेट करनी है मैनेजमेंट, वो उसको देख के करनी है. एंटी वेजेफ वो अफोर्ड कर सकता है, नहीं करता, सरकारी हॉस्पिटल है, प्राइवेट है, फिर मुझे उसके मुताबिक उसके फॉलोअप हो सकता है, नहीं हो सकता. मैं लेज़र की तरफ जाऊँ, मैं इंजेक्शंस की तरफ जाऊँ. एनाटॉमिकल और फंक्शनल में मेन जो एक चीज़ विच आई वुड वांट टू क्लैरिफाई वुड बी वेदर इट इज़ इस्कीमिक और नॉट. If DME is ischemic, then my steps would be different, and if it is non-ischemic, then my steps would be different.
Okay. Would the chair like to add something? Because he is writing from the very beginning.
I'm actually writing a few other points which I'll summarize that.
Okay.
Because
fair.
I just listened to a very nice presentation by Professor Mahfouz, and that is very pertinent for this very subject.
Okay,
so
we'll come back to that in the end.
Back to that.
So coming on to the question number 5, because does anybody want to add anything to? Yeah, please continue.
Just would like to add that anatomic success and functional, this is two different. Anatomically, you can have, better. Okay. Anatomically, the macula can, the thickness can decrease with your treatment, but the functional outcome may not be there, may not be reflected in functional improvement. And the factor which I would associate with these is chronicity of DME, control of systemic risk factors, and the presence of hard exudates. So the macula may dry up, but the functional improvement may not.
Perfect. Would you like to add something, Tariq?
Yes. There are newer areas which are introducing nowadays. There is a term by the name of drill, D-R-I-L. This is disorganization of the internal layers of the retina, which you can find on OCT, a good quality OCT. So the concept which previously we were having, that anatomical success and physiological success are not synonym. Now the OCT is showing that why they are not equal. So sometimes you are dealing with a patient having already disorganized internal layers. Sometimes there is a loss of the outer segments. The ellipsoid layer is not very healthy. Sometimes, as Dr. Shehzad said, you are dealing with ischemia. You are injecting, but the patient is not improving, sometimes even worsening. So when you do FFA, you are dealing with ischemia. And sometimes you are dealing with traction. There is ERM, and that is actually causing worsening. So all these factors are the prognostic factors which definitely have.
Saif, would you like to add something to it? Okay. So looking at the functional and the anatomical, what I gather is that there can be a balance, yet not a balance between the two, depending on whether sometimes you get a better result in the anatomical treatment, and sometimes when you're looking at it, you get better results functionally. Okay, question number 5. Like I said, it's a continuations and a repetitions. Basically, we're having 20 here, so once the first question goes away, it should come back to you so that you can add and collectively decide. First, the first question should be a continuation, and by the time you reach the 5th one also. So the 5th one comes to Mirali Shah. Shahzab, is there a need to focus on systemic associations when treating DME and maculopathy, and if so, why?
Yes, I think it's always needed. We have to control the etiology. If we remember that SAVE criteria, what is uski surface subretinal fluid कितना है, उसकी surface पे abnormality कितनी है with macular traction, उसकी atrophy कितनी है, ischemia कितनी है, and at the same time these diseases produced by the systemic disease. The eye problem is provoked by the systemic cause, so we have to control that. Including including me, we always, most of the time, we forget the lipid status of the patient, and the hard exudates the lipids contents of the serum lipid level. So we have to control everything. Keeping in touch with the endocrinologist and the hypertensive status of the patient. If that is controlled, वो सैलाब वाला system है कि अभी दीवार बांधे सैलाब फिर आएगा. Thank you.
Okay, Sanala Sahab, what else besides that is talked about the lipid profiles? What else is important in the systemic ways?
All the risk factor which you associate with diabetic retinopathy, lipidemias, hypertension, smoking, nephropathy, and all the risk factor which should be on your finger. And this is the most important thing when you are dealing with diabetic retinopathy or DME patients. This is my say about it. All the inflammatory mediators like VEGF and all these things, angiogenic factors, they will be produced more when there is poor control of all these systemic risk factors. So if they are controlled, you are in a better position. Your treatment, ocular treatment will yield better results.
Perfect. So I think one thing I'd like to add is that, because there are lots of women sitting here, but also we need to look into the thyroid also. Because I think in my practice, I've seen that women especially, because if you 1 in 4 are hypothyroid, and so when you have a thyroid issue, it also plays havoc with your diabetes. So we should always look for an underlying cause, because we're treating DME, but the basic thing is that we have to treat the diabetes. And looking at the systemic associations, and I think one of the, besides other autoimmune, I think thyroid is also a very important thing. Somehow that seems to be missed out. So,
pregnancy.
oh yes, and because you have gestational diabetes mellitus stays on and then you have issues. So question number 6 goes to Dr. Ahmed. Ahmed, what anti-VEGF protocol is routinely followed in DME in your practice? So we're not talking about it at the moment. This question I will take from a couple of you people because now we're talking about your practices rather than a universal guideline. And how often is OCT and OCTA, which is the talk of the town these days, repeated for DME patients?
I think initially when the DME patient comes to you or comes to me, it's very important thing is assessment. So definitely you have examined the eye, but if you don't do OCT, you can miss a lot of things. A few things as already mentioned, the tractional element can be there, taut posterior highlight face there, you can't pick it up. OCT angio again can help. I don't do routinely in all cases, but if the vision is poor significantly and I'm not seeing much changes, I would go for OCT angio. I will even go for fluorescent angiogram in those cases. And usually anti-VEGF protocol, what I start with, I would ask for the systemic risk factors to patients, any ischemic heart disease or any other issues. Then I may go for selective anti-VEGF, but otherwise I give the option of all three. It all depends on socioeconomic status of the patient as well. Because it's not only 1 or 2 injections that you're going to inject. You need to talk to your patient that it may be 3, it may be 6, it may be 9. So you have to tell them exactly that it's a longer duration of the treatment. And systemic control, as we were discussing, it is important according to Wikipedia's or DCCT study. So I'll start with the 3 injections monthly. During that time, I will check vision, but I won't do OCT on every visit. I'll give 3 monthly loading doses, then I would do the OCT, see how the response is coming. If no response coming, I will revisit my diagnosis. Okay. That am I thinking right? Am I missing something? Maybe there is ischemia there significantly, that's why it's not responding. So I'll go for either fluorescent angiogram at that time. If the response is coming, I will carry on with the same treatment. Okay. And I continue up to the time the fluid dries up. Because if you stop it, fluid comes back, wax and waning, that's not good. And that's going to cause more drill, as Dr. Irfan mentioned, or outer retinal damages.
Okay. Shahzad, would you like to elaborate?
Madam, I would want to point one thing कि हमने OCT को बहुत simplify कर दी. Thickness, we base everything on thickness. थिकनेस ज़्यादा होगी तो दैट मीन्स कि हो जी हमारा एंटी-VEGF काम नहीं कर रहा. थिकनेस कम हो गई तो हम बड़े खुश हैं कि एवरीथिंग इज़ गोइंग फाइन डिसरिगार्डिंग द पेशेंट्स विजन. OCT को हमेशा आपने क्लिनिकल कोरिलेशन के साथ देखना है, एक चीज़. सेकेंडली बेसलाइन OCT इज़ नॉट जस्ट कि इसकी थिकनेस 350 थी तो अब मैं 3 इंजेक्शंस के साथ इसको 250 पे लाऊंगा. ERM तो नहीं है साथ, कोई विट्रियो मैकुलर एडहेजन तो नहीं है. आपको इसी तरह से OCT एंजियो में आपका जो एवेस्कुलर एरियाज हैं वो कितने हैं और कहाँ कहाँ हैं. तो इस सारे को इकट्ठा करके देन वी नीड टू प्लान. लेकिन प्रोटोकॉल जो मेनली है वो तो यही है कि इफ़ द इंडिकेशन इज़ देयर देन वी गिव 3 लोडिंग डोज ऑफ इंजेक्शंस. आफ्टर द 3rd डोज 1 महीने के बाद हम फिर OCT रिपीट करेंगे एंड देन वील प्लान फॉर.
So the question is, what anti-VEGF? I know that we have the 3 different types and the 4th one is also just landed but it has some issues and all that. Which in your practice would you like to start with, or you just favor, you feel that it's got good results?
Based on all the studies that have been carried out regarding different anti-VEGFs, more or less every anti-VEGF has the same result.
लेकिन आपकी क्या practice, आपकी क्या है?
मैडम मैं सारी चीज़ें पेशेंट को बताता हूँ. हाँ, अगर उसको कार्डियक इशू है तो आई वुड अवॉइड एवेस्टिन. अगर नहीं है तो आई गिव देम द ऑप्शन ऑफ ऑल द 3 इंजेक्शंस एंड लेट देम डिसाइड कि वो कौन सा करते हैं. देखें 1 लाख का इंजेक्शन लगाना हो तो इट्स हर एक के लिए पॉसिबल नहीं. वो सुन के ही उसकी डायबिटीज़ और ख़राब हो जाएगी. तो अगर एवेस्टिन वो एक्शन दे रहा है तो वी स्टार्ट विद दैट. अगर उसमें नहीं आता तो देन वी कैन मूव ओवर टू द अदर.
तारिक,
इसमें मैं एक चीज़ को ऐड करना चाहूँगा. यू मेंशन कि आपकी क्या प्रैक्टिस है.
जी, this was the main thing.
Yes, but you know there are randomized trials which are giving very clear concept when to start treatment and how to start treatment. और उसमें चूँकि यहाँ ट्रेनिज भी काफ़ी बैठे हुए हैं, I would like to mention that if center is not involved and it is off-center edema, the best treatment is not anti-VEGF.
But there is a great role, and the mentioned treatment is peripheral laser. So Laser peripheral is advised, macular laser is not. So this is yet to come to our practice. We have, honestly, I don't have any experience about it. And while adding to the previous question, the important thing, as Dr. Tariq mentioned, is the patient's OCT, its cystic spaces, and the vitreomacular traction. If vitreomacular traction is there, we have to explain to the patient, we will give you an injection, maybe anti-VEGF or combined with steroids, but later on, after a month or so, the treatment will be surgery. We have to remove the epiretinal membrane.
Yes, sir.
May I add a few points? We all have been using anything and you'll get it. But that is not the point. We have to be scientific. So what, as you said, what is my protocol is I will start with the anti-VEGF, whether involving the center or not. And after first or second dose, I will go in and I will do the focal laser, whether it is involving center or not, because that will eventually will involve the center. Why wait till the center is involved? So if you see these juicy areas, go in, even on the first visit. If you see that the thickness is not that much that it is hindering your laser, go in, do the laser. But as far as the peripheral retina is concerned, yes, you're right. Ischemic areas must be knocked out. But you being the VR surgeon, you people are too aggressive about it. I have seen retinas being totally knocked out by the VR surgeon, which is, once we see them, I'm not a VR, I'm a medical retina specialist. So we feel bad. Look, why khadas? They literally dig tunnels inside the retinas. So the trainees must be taught that if you're going away, increase the spot size. Intensity you can always switch over. But they keep the same spot size. They are doing the same inside the arcades as well as the outside. So these trainees, we being too busy, we always, okay, you are third year resident, you're 4 years resident, you know how to do it, okay, do it. And these are the trainees, who are practicing on these.
So let's do this. Let's put this on the trainees rather than on ourselves.
No.
Rather than calling the retina and all that.
We have to teach them.
Sir.
We have to teach them.
He's,
I think
Professor Saqib is right. We are forgotten, and because of the flow of a Western everywhere, and not only by the VR, in every center, Tahsil district, everybody is good using, and availability is good using a Western. But this is by the time they reach the VR, जो आप बदनाम हो चुके हैं.
नहीं बदनाम की बात नहीं.
हमें जल्दी से
I think just quickly, I will mention here about protocol T. उसने बताया कि सारी anti-VEGF काम करती हैं और reasonably around काम कर रही हैं. तो yes, aflibercept we know if it's 615 or less, it has been much more superior. But all anti-VEGF work, you have to select it. And I think I would agree, if it's not center involving, just do focal laser. You just need to do focal laser. You don't need to do anti-VEGF, because I have seen the patient 6/6 vision. Patient was injected endophthalmitis and patient turned blind. So that patient said, मुझे तो डॉक्टर साहब मसला ही नहीं था, कि मुझे पता नहीं क्यों डॉक्टर साहब ने लगा दिया. And problem, और इसमें भी यही है कि VR और medical retina, I think that's again because VR सारा संभाल नहीं सकते medical retina को. We all need to, the purpose भी जो ये talks arrange करने का मकसद डॉक्टर उमा और हम लोग का यही है कि judicious use हो anti-VEGF की, lasers का आपको पता होना चाहिए चीज़ों में, क्योंकि VR specialist सारा काम नहीं कर सकते. Yes, selected patient need to go there. अगर पहले पेशेंट प्रॉपर्ली मैनेज रहे हैं, हम VR के लिए आसानी होगी. अगर नहीं मैनेज, हमारे लिए और मुश्किल होगी.
So I think we're going to the next. We're going to the next. Sir.
We have already started this 2 weeks back in FIU. Now we have got one department which is known as retina department. On the right you have the surgical, on the left you have the medical. So your workload is now being shared by the others, so that they are not busy injecting everyone.
So
And
that's wonderful. So I think this question that is highlighted, I think we can skip it. We can go to the next one, because not all of us are like using the wide field geography, but I think it's a very vital thing. And
I just
if
want
possible,
to mention one sentence for trainees. Remember, the peripheral laser PRP is one of the treatment for DME. And this wide field angiography actually helps us to
pick up
find
those
any
points.
ischemic area which are not possible within the conventional system.
And not to mention the sub-threshold lasers also.
Yes.
We should talk about them also. We're going talking about just the focal lasers. We're talking about the like high heat one. There are sub-threshold lasers available in the market. We're just not promoting them as we should, because I think those are the ones that are more beneficial for the a small, maybe just on the top of fovea, the DMEs. Okay, now we go to the question number 8, and half time has passed, so we're almost on the half of the questions also. Now I'm going to join these two questions, so please look at them. Does density and location of heart exudates affect treatment outcome of DME? Will heart exudate macular area addressed in the same manner as DME? And how long does it take for heart exudates to resolve? So let's combine these three because it's one after the other. So now let's have.
This is real most. In my practice, these exudates, the macula may decrease, the thickness may decrease. This will not be reflected in improvement in visually. The calcification will stay there and will take months to disappear for exudates. So for me, in such cases, there will be no functional improvement ultimately after loads of injections. And the thickness may decrease and the vision will be just counting finger at it. The other problem with such eyes are if there is proliferative diabetic retinopathy in these eyes and you would like to go for PRP, you will destroy the peripheral retina and the peripheral vision also. So these are real monster and it's real difficult to treat.
By the way, this picture that, ladies and gentlemen, that you're seeing is actually of a patient, of my patient. So it took me 5 years to settle the exudates, the edema, everything, but the 5 years that it takes a very long time. So मेरी practice में तो बहुत time लगता है, इसलिए it was very close to my heart, I brought it. Can we have this from Shahzad?
मैडम अगर heart exudate sarcinate pattern में हो तो I would be very happy because I would know exactly what to do, where to put the laser. ये जो situation है, this means कि the things have gone pretty bad. इसमें हम चाहे anti-VEGF लगा के edema को कम कर दें या laser की अगर option बनती है वो कर दें. जो सनाउल्लाह साहब ने कहा कि विजुअल एक्विटी तो मेन चीज़ है, पेशेंट को तो विजुअल एक्विटी चाहिए, वो नहीं इम्प्रूव होगी. एंटी लिपिड भी हम देते हैं. अब इसमें हाउ लॉन्ग डज इट टेक, इट डिपेंड्स वेरिएबली, बट डेफिनेटली इफ दिस सिचुएशन इज देयर इट मे टेक अ लाइफ टाइम फॉर देम टू गो ऑफ. तो पेशेंट टू पेशेंट थोड़ा वेरी करता है.
Amen.
I think two aspects here. एक तो exudation massive है, that Dr. Homa has mentioned, we need to inject and you need to keep on injecting every month. And I have seen patients heart exudate disappear or at least disappear from the center and their vision improves. So you need to keep going, maybe year, 2 year, you need to inject. Other important thing I think we are forgetting here is systemic cholesterol control. You need to give a lipid lowering agent because that also again help to get reduction of these exudates. So patient's vision will improve, but it takes patience and lot of injections.
Shahzad?
These are the patients in which we can advise the use of steroids. Nowadays, Kenacard, we try to inject 1 to 2 milligram intravitreally combined with Avastin. And these are the patients that if there is a response, the second question is how long it takes. It's the literature mentions 3 months. It takes for the heart is 3 months, and for the soft exudate for the 10 is in weeks. Okay. If they are responsive treatment, they'll absorb. And in such cases, if repeated injections and everything fail, you have to wash out this exudate by retinotomy and subretinal wash.
I think Tariq wants to add.
Yeah, there is only...
This is a very interesting question, so we will, we can take it for another 3-4 minutes. Yeah, go ahead.
As you said, because if the exudates are fresh, they can disappear in months. Such exudates, in my experience, they will stay for years. And even after a lot of injections, they are not going to disappear. The calcification, that will be burning. This is my experience.
Okay.
There is only one study, sorry.
Did you go ahead, please go on.
There is only one study which is a randomized clinical trial, the RISE and RIDE trial, which has actually studied these cases with the foveal heart exudates. And to everybody's surprise, the foveal hard exudate is not a bad prognostic factor for the success of the treatment with anti-VEGFs. Yes, if you see the hard exudates are lying within the inner retinal layers, and definitely it will affect grossly the visual acuity. But with the treatment, with the continuous treatment of anti-VEGFs, it does disappear, and the vision definitely improves when it disappears. The main thing is that no, I'm not talking about this. I'm generally
सर ये
saying.
पिक्चर मेरी पेशेंट की है, मैंने साफ कर दिया हुआ है, इसलिए मैं तो लेकर आई. It takes time. Sometimes
It will
miracles
definitely
happen.
It will definitely take years, but it will definitely respond. If it is not responding, then we should revisit the other aspects why it is not responding. Like there may be systemic risk factors which are not being addressed. Like there may be some anatomical other factors involved in the fovea which are not letting this hard exudates go away.
My
So-
question to the
मैडम
panel.
मैडम एक सिर्फ
in the
मुझे
same-
बताइए, इस पेशेंट के फॉलोअप्स हैं आपके पास?
मेरे पास इसका follow-up है, मैं
क्या हुआ?
I'll share it. The center has cleared and I don't know how it happened frankly because उसको हम anti-VEGFs लगाते रहे, but there was something else which was very important was, sorry इसको मैं वापस ला रही हूँ. He was a smoker also, so you have to have he was put on lipids जो आपके होते हैं statins and all that, and apart from that उसको lifestyle हमने बहुत किया, weight loss, so many things, smokers. So जो think है कि smoking aspects and all that has to be it is multifactorial. It's just not anti-VEGFs that are going to work. You've got to look at the system. You're going to have an endocrinologist. You've got to have a physician on board with these people because इनमें blood pressure के भी issues होंगे, इनमें sugar के भी issues होंगे. So you need to look into all and then tell the patient, be persistent, wait, and miracles happen. So can we move to the next question,
No, madam,
if allowed?
One question to
So
the
20
panel
minutes
as
are
well
left.
as for you.
Minimum,
Was
sir.
this patient put on phenofibrate? Because now there are a lot of studies which are coming out that it stops the progression.
Yes.
It's a lipid lowering agent.
Yes.
Why not put these patients right from day one, which are threatening with the hard exudate, on phenofibrate?
सर मैं तो फिजिशियन से बात करके ना फिजिशियन से बात कर उनको फॉरवर्ड भेजती हूँ कि इनको लिपिड्स नहीं सर मैं खुद इतना आई वुड प्रेफर कि एक फिजिशियन इज ऑन बोर्ड. Okay, it's always good because it's a multi-system ना, तो बेहतर है कि you have a couple of other intelligent people on board also. So we go moving to the question number 10 and let's join them together. What clinical diagnostic factors are used to label resistant DME? ना शहजाद को ये resistant के word से बहुत चिढ़ है, so let's start with him.
मैडम
इसको पहले मुझे ठीक कर दें, आपने लास्ट टाइम भी ठीक करने की कोशिश की थी the words resistant.
मैडम रेजिस्टेंस अब डिपेंड करता है कि हम रेजिस्टेंस किसको कहते हैं. पहली बात तो कंप्लायंस की है. देखें ये जो डायबिटिक मैकुलर एडीमा या डायबिटीज़ मेलाइटिस जो है ना, ये टग ऑफ वॉर है. जो ज़्यादा ताकतवर होगा वो जीतेगा. ये नहीं हो सकता कि हम सारा कुछ कर रहे हों और 13 और 14 पे हीमोग्लोबिन A1C हो और हम कहें कि ये तो रेजिस्टेंट है पेशेंट. तो आपको एज इन टोटलिटी लेना है कि उसकी डायबिटिक कंट्रोल कैसा है, किस टाइप की डायबिटीज़ है, उसका लाइफस्टाइल कैसा है, वेट कैसा है, हाइपरटेंशन साथ है या नहीं, नेफ्रोपैथी, स्किन डिजीज़, वो सारी चीज़ें जो हैं वो उसके साथ एसोसिएटेड हैं. रेजिस्टेंस वुड बी अगर हमारी ट्रीटमेंट और उसकी जो कंप्लायंस है वो सही है एंड स्टिल वी आर नॉट सीइंग एनी इम्प्रूवमेंट इन विजन ऑन OCT एंड इफ रिक्वायर्ड FFA, देन वी वुड लेबल इट कि ये रेजिस्टेंस है ट्रीटमेंट को, और फिर हम नेक्स्ट पे जा सकते हैं. शायद आगे वो स्टीरॉइड्स का भी जिक्र अभी हुआ था,
अभी
एंटी VEGF के बाद हम और भी ऑप्शंस हैं जिनको हम
So
एक्सरसाइज कर सकते
अब
हैं.
मैंने कहा था 10 and 11 को हम ऐड ऑन कर रहे हैं. What factors are responsible for the development of this DME? So आपने ऑलरेडी कुछ तो कह दिया. If anybody wants to add on कि क्या क्या और फैक्टर्स हैं जो आपको ये रेजिस्टेंट या रिफ्रैक्टरी या whatever word you want to say that your result you're not getting the results you want.
Sorry.
Sure.
You want to answer? No, that's correct.
Well, there are three terms being used together. One is resistant, one is refractory, and one is persistent DME.
Resistant kernels आपको नहीं पसंद?
सही,
This word.
ये तीनों टर्म्स आप यूज़ कर सकती हैं. बाय डिफिनीशन रेजिस्टेंट और रिफ्रैक्टरी DME वो है जो 3 कंसेक्यूटिव इंजेक्शंस के बावजूद भी विजन को 6-9 पे ना ले आ सके, या जो सेंट्रल मैकुलर थिकनेस है वो 300 माइक्रोन से नीचे ना आए. If this is happening, this is a refractory DME. This is a standard definition of refractory DME. Now, ये क्यों है ये तो there may be so many reasons for that, लेकिन generally speaking, the prevalence of refractory DME is more than 50%. जो हम जितना DME देखते हैं उसमें more than 50% cases ऐसे हैं जो 3 इंजेक्शन से 300 माइक्रॉन्स तक नहीं आते या 6-9 तक इम्प्रूव नहीं होते.
Okay. And
मैं एक सिर्फ थोड़ा सा मैं आई टेंड टू डिसएग्री. अगर हम एक स्टेप भी आगे बढ़ते हैं तो दैट मीन्स के वी आर मूविंग. अगर फॉर एग्जांपल उसका एडिमा 300 से 280 पे आता है तो दैट मीन्स के कुछ ना कुछ तो उसमें बेहतरी आई है. वी कैन नॉट कॉल इट रेजिस्टेंस. 6/9 विजन तक तो आने में हो सकता है उसको 3 इंजेक्शंस लगें, 6 लगें, 9 लगें, डिपेंडिंग ऑन व्हाट द एक्चुअल सिनेरियो वाज. तो अगर तो बेहतरी आ रही है तो फिर तो ठीक है, इट्स नॉट रेजिस्टेंस. और ये और हो सकता है कि उसकी पेस हमारी मर्जी के मुताबिक ना हो, तो वो फिर हम ऑप्शंस उसमें ऐड कर सकते हैं, मसलन एंटी-VEGF के साथ स्टेरॉइड्स को ऐड कर.
European guidelines about these resistant cases is that
करीब कर लें.
whatever you do, 40% or more than 40% are the cases will not improve the vision and the edema will not improve. So with all the available resources, they are helpless. Now they are aiming to change the guidelines for inclusion and find some others, and probably they are going towards early surgery. Then in these cases you have to go for early surgery, because in these 40% in good, the best center in the world, they are unresponsive to treatment. Whatever you use, even steroids, ozurdex, everything, the 40% will not respond.
So I think the next question is in continuation of what you've just said. Can you label a DME as an inflammatory response? And if so, at what stage and how is it managed? This I leave to any one of you to answer.
Okay, just a comment about the previous question. That can you go back to the previous?
This one?
The clinical and diagnostic factors which leads to a resistant DME. I would say the systemic risk factor control, that is the most important. If you are not controlling the risk factor which are the base for this DME or this diabetic retinopathy, your treatment, whatever you are giving, that will not be effective. Second would be the chronicity of the diabetic macular edema. If the patient presents very late and the edema is present for long duration, then it may not be responsive to your treatment options, whatever steroids or anti-VEGF. The presence of hard exudates, again I would say this is bad prognostic factor. If there hard exudates are there, your treatment may not be as effective as without hard exudates. And the next question. Now, because the inflammatory mediators are already there, the VEGF and all that, that's why we are injecting steroids and anti-VEGF. So they are important, and these are related directly to your systemic risk factor control, diabetic control and other risk factor control. So if you can control that, again, there is your treatment, whatever you are giving them, will be more effective.
Okay. Could you like to, would anybody like to add, or we move to the next one?
In fact, it's multifactorial. इसमें इन्फ्लेमेशन भी है, इंक्रीज परमेबिलिटी भी एंजियोजेनेसिस है. वो जो PIA का जिक्र हुआ था कि परमेबिलिटी and angiogenesis, all the three factors are responsible. Now it's the battle between the three, which two are more prevalent. So we have to keep an eye on that and control it.
Okay. So we will start with you, Shahzad. How often do you call it resistant? How often you think that now this is an inflammatory aspect involved, because inflammation, we in a way have a feeling, a consensus that inflammation does have a role in DME, especially resistant, refractive, persistent DME. So looking at that, what is the role? Is there a role? What is the role? And when would you like to intervene with these steroids? So we're combining the question number 13 and question number 14.
Definitely it has an inflammatory aspect, because when we didn't have anti-VEGFs, we had intravitreal steroids, and we have been using them for quite some time. अब जब से anti-VEGF आए, we have shifted because उनकी efficacy ज़रा different थी. जहाँ पर फिर वही बात कि अगर फ़र्ज़ करें रेजिस्टेंस आ रही है और हमें वहाँ पे ज़रूर इंट्राविट्रियल और सुप्राकोरॉइडल स्टेरॉइड्स का इंजेक्शन देना चाहिए. आई हैव सीन अमेजिंग रिजल्ट्स विद इवन वन इंजेक्शन. सेकेंडली, अगर कहीं पे VMA या ERM है तो आई वुड बी स्लाइटली अनकम्फर्टेबल गिविंग एंटी-VEGFs. मैं वहाँ पे स्टेरॉइड्स पे आई वुड बी मोर कंफर्टेबल कंसिडरिंग कि जो कॉन्ट्राइंडिकेशंस हैं उस स्टेरॉइड की अगर वो रूल आउट हो जाती हैं तो देन आई वुड बी वेरी कंफर्टेबल इन गिविंग इन केसेस विच आर नॉट रिस्पॉन्डिंग टू एंटी-VEGFs.
Okay. Amir?
I think in my patient, mostly I use anti-VEGF, but if the patient is having ischemic maculopathy, in the start I would start with the steroid. I do combination in those cases, like I use anti-VEGFs as well, I use the steroids as well. But if the patients are not responding, you have given multiple anti-VEGF and you revisit your diagnosis and that comes out to be that there is a proliferative diabetic retinopathy or ischemia there. In that case, yes, laser, and then I would go to the steroids. Coming to the route, I think there are multiple routes, as we know, Ozurdex works, Retisert, they are different things which are not available in Pakistan. I was using one in UK. Here, I think the best route which we are using nowadays is suprachoroidal approach, which is brilliant, relatively less risk regarding the glaucoma in comparison to intravitreal steroid. So that can be a good option.
Sounds up. सर एक चीज़ मैं सिर्फ ऐड करना चाहूँगी, इसको थोड़ा सा क्लैरिफाई कर दे. जो मेरे माइंड में इनके पास सवाल आ रहा था कि अगर हम स्टीरॉइड्स देते हैं और सुप्राकोरॉइडल्स, बिकॉज अब ये जो टॉक ऑफ द टाउन आ गई बेसिकली कि सुप्राकोरॉइडल्स यूवाइटिस में आ रहे हैं, DME में आ रहे हैं, परसिस्टेंट में आ रहे हैं, फर्स्ट लाइन में भी शुरू इन अ वे कहीं मैंने पढ़ा था कि फर्स्ट लाइन ऑफ ट्रीटमेंट में भी द ट्रायल्स हैव स्टार्टेड. Do you just focus on one injection as a combination or a separate entity? Do you combine the two injections together or you do it separately, and how often? So please इसी को continuation में कर दीजिए, something that I missed out.
कई क्वेश्चन एक साथ हो गए.
सारे साथ हो गए.
Steroids, of course, they have a role in management of DME, and intravitreal तो यूज होते रहे पहले, लेकिन बाद में लॉन्ग एक्टिंग प्रिपरेशन आ गई, रेटिसर्ट, ओजरडेक्स, और उन्होंने भी उसी तरह एफिकेसी शो. अभी सुप्राकोरॉइडल आ गए. अब इंट्राविट्रियल स्टीरॉइड के साथ, आई मीन they were giving the similar results as anti-VEGF, but they at the cost of cataract and glaucoma. So you have to be selective in treating your patient. Suprachoroidal, I would say, is much better route for steroid injection, and they do very well. The improvement which you will get with multiple anti-VEGF injection, you can have that with single suprachoroidal steroid injection. And again, I would also agree with Shahzad that if there is any traction or if ILM is prominent, then I would also like to go for suprachoroidal steroid.
Okay.
May I add to this?
I would like
इसके
to
बाद फिर आप करिए.
May I add to this talk? My next talk is on suprachoroidal, and we will be discussing the same subject in depth.
Just
Sure.
one comment, Tarek, because combination, I only try combination in desperate cases. If they are not responding, then I may go for combination.
Okay.
I think the pathophysiology or etiopathogenesis of DME is not the same in every individual. So whenever we are treating these patients, we have to individualize the patients. And number two, most important is that we have to get to know about the etiopathogenesis in that particular individual while treating these patients. I mean, you cannot treat with one line treatment every DME patient. Steroids are helpful because indirectly it has been seen that the VEGF, the cytokines, the interleukins, the prostaglandins, they are all upregulated in the DME cases. So indirectly steroids do work. But I mean, every patient to start with steroids. Again, I am injecting suprachoroidal for the last 2 or 3 years. But just for your information, there is no randomized, multi-center clinical trial up till yet available for this particular route.
Okay. This question, I would like to take an experience from the people who are sitting here. So if anybody would like to give the experience, please introduce yourself and response in 2-3 minutes. Ji, Hena? Hena, 2-3 minutes. Okay. आवाज है?
Am I audible? Hello?
Hello.
I'm Dr. Hina. I work at Amanat Eye Hospital as the lead of medical retina service of the hospital. Thank you for the opportunity to just put in my 2 extra pennies in here. It's a wonderful discussion and I'm humbled to be speaking. I think in my experience, what I've imagined is there's that debate about whether to use anti-VEGF or to use steroid. But another
Or combine them.
Or combine them. But another important question is when to shift. So with due regards to Professor Tariq, who did the fact of the TRCR protocol trials was that only 40 to 50% of patients show the ultimate optimal response. And when they don't, after 3 injections, it is very unlikely that they will after another, 6 or 7 or wherever it is. So another 20% perhaps goes up to that optimal response with repeated anti-VEGF. So there was a big, they've recently published in British Journal of Ophthalmology, a group of 8 medical retina specialists up north of England. They come up with a consensus that A, we need to standardize what we call a response, an optimal response iski baat ho rahi thi. You mentioned vision better than 6/9 or CRT less than 300, but the CRT would actually be dependent on the baseline CRT. So I think more appropriate term would be an improvement of beyond 30% from your baseline. That is a good response. You continue with anti-VEGF. Otherwise, even after the 3, based on what I've just said, I seriously consider shifting to steroids at that point, because there comes a time where I have injected even Ozurdex implants with very good response, but nothing there to salvage because of photoreceptor damage and the chronicity of the lesion. The patients respond very well. You look at the OCT, you're very happy, but the functional return is not there.
So the thing, the question, half of the question is still somehow left behind. How many suprachoroidals would you be giving to a patient of DME? You'd like to give it anti-VEGF, so continue giving anti-VEGFs on a monthly basis. So how many would you consider to should we do just this one suprachoroidal and then continue with the anti-VEGFs, or repeat a suprachoroidal after a month or 2, just like we do anti-VEGFs? So I think this is something for the trainees who'd like to know, okay, what is the importance of steroid? And just a short 30,
So,
if you can finish in 1 minute.
Once you have a periocular steroid in place, then the average duration of action is about 8 weeks. So once I've done suprachoroidal and I've had a good, it's not about suprachoroidal, it's more of the steroid. So once you've done treated with the steroid and you've got good response, you wait till 8 weeks anyway, because it's going to, and then I don't repeat unless I see worsening on OCT.
Okay, what about anybody else? Because now we go to the surgical retina.
May I add to this? There are 2 studies.
So 2 minutes.
Peachwood and Dogwood. They describe after suprachoroidal, you can repeat after 12 weeks, but not after that. It's not going to respond, it will not respond.
Okay.
एक चीज़ मैं इसमें कहना चाहूँगा कि फॉर माई प्रोटोकॉल विच आई एम फॉलोइंग इज कि जब मैंने स्टेरॉइड देना तो मैं उसको फिर फॉलोअप पे उसका वर्कअप करूँगा, विजुअल एक्विटी स्पेशली और बाकी चीज़ें, टू सी कि अगर उसमें बेहतरी आ रही है, देन आई वुड डिसाइड फर्दर मैनेजमेंट.
Shah Sahab, and we're going to finish the another.
It is severely affected when there is cystoid macular edema and chronicity. There is a visual loss, the history में कि काफी 6-7 महीने improvement नहीं हो रही. That is the time to combine the anti-VEGF as a first line with the steroids. And in fact, this steroid will save the monthly injections. We can wait for another 3 months.
Wonderful. I would encourage especially the trainees, the trainers and the trainees, that if you can, just like I said, there is not the trials have not been done. Why don't we do it here? You have the opportunity, you have the teachers. Why don't you present in your dissertations and all that? And we will come to a good paper maybe in the future. So now we're going towards the surgical side of DME. I would ask this question from Sanala Jansa, because this is something which unki smile se tha ki this is something he'd like to address. Is passband vitrectomy a solution to resolving DME? If so, why? But I'm going to combine the other one also. How early should we opt for DME and why? So let's combine these 2 questions together.
Actually, vitrectomy is not standard protocol for treating DME, but some studies have shown some promising results. Somehow they don't know the exact mechanism, but the oxygenation of the macula increases and that decreases the macular thickness and visual acuity is improved. But these are not randomized controlled trials.
Okay.
So this is not standard protocol. Yes, in very desperate cases, sometime you may opt for vitrectomy. For me, it will be very rare to go. If there is traction or tight ILM, that's different story. But if there is no traction, then I would very rarely go for resistant or very refractory DME.
Amir, would you like to add to this?
I think regarding early, I will go only for tractional DME. If there is a tractional element, either taut ILM, taut posterior highlight phase, or there is a vitreomacular traction there, I would definitely go for vitrectomy. But otherwise, I would keep it as a late resort. I think it helps in two ways. One thing is a tractional. Other thing, if there is significant ischemia, you can't do laser up to the ora serrata. But when I'm doing a vitrectomy, I've got the good opportunity. I can do the brilliant laser at that time. So that also helps. If VEGF load is too much, I think vitrectomy will be useful in that case.
How early? I mean, the question is how early? What you consider early? Traction. So that can be within a month.
I think I won't give any
when your
injection.
first injection.
Yeah, tractional I won't give any injection or anything. I'll go for.
जी शाहज़ाद.
मैडम इसमें I think before the retina dies, we need to do something. हमारे पास आप तो नहीं मतलब हमारे पास
ये तो मैं इसको
सर उस वक्त भेजते हैं when the retina is already more or less dead. अब फिर जब हम डेड को वापस जिंदा नहीं कर सकते तो हमारे पे इल्ज़ाम आ जाता है जी आप लोगों ने क्या सर्जरी की, कोई रिजल्ट ही नहीं आया, वो PL पॉजिटिव था और वो PL पॉजिटिव ही गया. तो जब उसमें वाइबल है, रेटिना की फंक्शनिंग कैपेबिलिटी है, उस टाइम पे आप उसको ऑपरेट करके उसको एटलीस्ट आप वाइबल विजन दे दें अगले कई सालों के लिए. तो आई थिंक अगर जैसे इन्होंने मेंशन किया कि एडवांस डायबिटिक आई डिजीज आ रही है, उसमें इंजेक्शन आप नहीं लगा सकते, उसमें आप पेरिफेरी तक लेजर नहीं कर सकते, तो आई थिंक वी शुड गो इन विद द सर्जरी.
Tariq sir, you want to add something?
There are 4 indications that have been mentioned for vitrectomy. One is DME with VMT, another is DME with ERM, one is just mentioned as posterior taut posterior highlight, and certain CME cases in which you should intervene. Definitely you should intervene in the dying stage rather than in the dead stage. So the earlier the vitrectomy is being done, the better would be the result. In fact, these are not the cases for injections.
Okay. So the last question, and जैसे कि majority यहाँ पे armed forces के doctors and all that बैठे, time पाबंद सबसे important मेरे लिए था. So इस वक्त तो we're finishing the 18th question and inshallah we'll finish on time. अब ये आप सब के लिए I think सबसे important tip, जैसे हमने शुरू किया था उसी पे हम इख्तिताम कर रहे हैं. क्या रीजंस हैं कि आप सब कुछ भी कर लेते हैं लेकिन कॉमन फैक्टर्स एंड रीजन जो फेल होगी आपकी डीएमई ट्रीटमेंट इन योर प्रैक्टिस, नॉट जनरलाइज्ड बात नहीं हो रही, इन योर प्रैक्टिस क्या मसला आया सर?
The most important or the common factor which I see in my patient is poor control of the risk factor.
Okay.
And I have done some hospital-based studies and I found that more than 80% of patients coming to IUPD or diabetic, they are poor, they are having poor diabetes. And 80% of them even don't know that what problems are, what are the risk factors which can worsen their vision or their diabetic retinopathy, things like that. So this is the most important. Second important is the compliance of the patient with your treatment. See if they can come back whenever you ask them, go for intravitreal injection, laser, whatever. So these 2 are the most important factors. Yes, other factors again, as say chronicity of the macular edema, presence of hot aggregates, ischemia, traction. These are some other factors.
Shazab.
3 C's are important in this: cost, compliance, as Dr. Sanolaja mentioned nicely, and counseling. So whatever I see in my practice, either it's the cost the patient cannot afford, we should try to spread these services to provide these services, especially the OCT and these medicine. If with some organization free of cost, then the patient's compliance is more. And in fact, even with the affording patient, the compliance is those who these patients become refractory. And our part is that sometimes when one injection is given, they say that's all and everything will be recovered with this. We don't do proper counseling.
Tariq sir, 1 minute. 1 minute, 1
Definitely
minute.
the reasons are the same which Professor Sanaullah Jan Sahab and Professor Mir Ali Shah Sahab have just mentioned. I endorse the same statement. But one thing I would like to add on our part, we should try to understand the pathophysiology of that particular patient. Every patient has a different mechanism of developing DME, and we have to treat accordingly.
Shahzad?
मैडम वन वर्ड इस्कीमिया. अगर इस्कीमिया तो फिर DME ट्रीटमेंट रिस्पॉन्स कभी भी हमें ऑप्टिमल नहीं मिल सकती. सो वी हैव टू फाइंड आउट दैट इस्कीमिया एंड वी हैव टू ट्रीट दैट इस्कीमिया एज पर द प्रोटोकॉल्स.
Amir?
I think one important thing is a patchy treatment from our side. Like if हमने एक इंजेक्शन लगा दिया, 3 लगा दिया, बस पेशेंट को कहा बस अब चले जाएं. You need to carry on until they get rid of the fluid. Because अगर fluid आता जाता रहेगा या persist करेगा, that's going to cause the damage. और बाद में आप फिर जो मर्जी कर लें, अगर retinal structures are damaged, patient is not going to get improved.
सैफ आप कुछ ऐड करेंगे?
मैं भूल गया हूँ 3C में एक 4 था
Fourth C.
chronicity.
Chronicity. Would you like to add something, Sir? Into this last, the practice and all that.
मैम बेसिकली जितने पेशेंट्स आते हैं डायबिटिक मैकुलर एडिमा के, सबसे इम्पोर्टेंट चीज़ वही कॉम्प्लाइंस है और कॉस्ट. बेसिकली इस चीज़ के लिए जो है वो हमारे एरियाज़ के अंदर जो है ना, जो पेशेंट्स हैं, हमें जो प्रॉब्लम्स होती हैं वो बहुत दूर इलाकों के होते हैं, तो इसलिए वो कॉम्प्लाइंस सही से नहीं कर पाते हैं. तो फिर हम लाइक स्टेरॉइड्स भी यूज़ करते हैं इसके अंदर, लाइक एंटी वेजप्स भी यूज़ करते हैं, लेकिन मोस्टली के compliance or...
So I'll just, as a moderator, maybe it's the last point that I just like to add it, that we need to consider every patient as, सब कहते हैं ना, designers and all that कहते हैं, tailor-made treatment. So I think you cannot have one treatment that I have for my patient the same for the other patient. You have to decide the compliance. You have to look at the cost. You have to look at the chronicity. Every patient of diabetic macular edema will have a different way of presentation, and you have to tailor-make their treatment plan, looking at all these things. So some people might not be able to come on the next visit. So you decide how to counsel them and how to, bring about a change in their life and how to bring about an improvement in vision. So I think important is that with all this, what we've talked about today, treat your patients as a separate entity and design their treatment plan accordingly, knowing the pathophysiology, knowing their where they're living, where they're coming from, their financial issues, looking at all these things, and then probably you'll be able to spare them from the concept of chronicity and resistance. Thank you so much, everybody. I'd like to hand over to Commandant Brigadier Saqib Naeem, who's the chairman, to end the session.
Thank you very much, Professor Huma. The purpose of such panel discussion is to highlight the important practical aspects of a very important subject like diabetic macular edema. And as far as the trainees are concerned, remember, we are all part of the examination circle here, and these are the very questions which we ask you in the exam. And please come prepared. This is what we do in practical life. One last point before, because we are running short of time. We had a very good talk by Professor Mahfouz from KPK, and he basically discussed what are the patients who are going to develop advanced disease at a very rapid and early age. So we still don't know, but they have devised a method. They have devised some genetic mapping. They are doing it as a experimentation at present, and they say that they can predict among those who present to us with diabetes who are going to have more aggressive disease. Let's hope in future that we can apply this in our clinical practice. Then all your things which you have discussed, that should we go for an early vitrectomy or not, these are the very suitable patient for that.
So ये तो era of artificial intelligence है ना.
तो मैडम तो वो आप प्रोफेसर महफूज से तो मैंने अभी कहा वी आर गोइंग टू हैव अ वेरी बिग डिस्कशन ऑन दिस बिकॉज़ दिस इज वेरी इंपॉर्टेंट फॉर अस. थैंक यू वेरी मच. आई क्लोज दिस सेशन. थैंक यू.
थैंक यू मैडम, आपने काफ़ी अच्छी तरीके से केस